welcome. My name is Garnet Gilmore, and I'm the Marketing Director at Warwick Forest, your premier sponsor for the Lifelong Learning Society. Today we're filming in the Commons Community Room. The community room is used for parties, it's used for gatherings. Sometimes people just grab a book and they read by the fireplace. We would love for you to come and take a tour. Please give us a call and we can schedule an appointment. I'm introducing Dr. Ward. Dr. Ward earned her medical degree from the University of Medicine and Dentistry of New Jersey. She completed an internal medicine residency at the University of Maryland Medical Center and a cardiology fellowship at the Jefferson Heart Institute in Philadelphia. Dr. Ward is board certified by the American Board of Internal Medicine and eligible for subspecialty certification in echocardiology, nuclear cardiology, and cardiovascular diseases. Dr. Ward is passionate about groundbreaking treatments and therapeutic options in cardiology. She encourages patients to be actively engaged in their decision-making. Dr. Ward is an advocate for the diagnosis, treatment, and prevention of women's cardiovascular disease. Born in New York City and raised at the Jersey Shore, Dr. Ward is new to Hampton Roads. She is excited to explore the area's history and learn to paddleboard. Dr. Ward enjoys being outside and spending time with friends and family.
So starting with echocardiography, TTE and TEE. So transthoracic echocardiogram is cardiac ultrasound. It's widely available, very reproducible, and is a non-invasive study. Transesophageal echocardiogram is also cardiac ultrasound, but it is an invasive procedure, and it does offer us superior visualization of posterior structures. And when we get to TEE, I'll review what those posterior structures are and why we see some images or some structures better. So first I wanted to do a brief overview of ultrasound history, just to say how did we get here and why didn't we think about this? So the 1910s sonar was developed, in the 1940s radar was then developed, and around that time it was proposed that ultrasound could be used to visualize internal organs. In 1953, Edler and Hertz recorded the first moving image of the heart. It was actually not a picture of the heart at all, but rather something called M node, which is just lines that I believe I have a picture of later to show you. So while you could see these lines which showed us a part of the heart, we weren't actually visualizing the structures like we do today. Then in the 1970s, 2D echo and pulsed Doppler became available. And 2D echo is the basis for what we use today. In 1982, color Doppler, pulse wave, and continuous wave became available. And in the 1980s, transesophageal echo was brought to the forefront. So as you can see, it was something that's been around and thought about since the 1950s, but it wasn't really until the 1980s that the technology became widely available, and even 3D became available even after that. Okay, so a brief overview of the history. I just thought that it was interesting to go through that. So now we'll talk about what is cardiac ultrasound. It's high frequency sound waves. There is a transducer that is put either on the chest or into the esophagus, depending on which one we're doing. It has something called piezoelectric crystals that transmit and receive ultrasound waves. There's then a computerized system that programs the waves that go out, processes the signals that are received, and stores the data. And then there is a display. So what happens if someone orders a transthoracic echocardiogram or TTE? So you arrive at the office or at the hospital, depending on where it's being done. There is a private room for scanning. You're changed into a gown, lie on your left side. There's ultrasound jelly that's placed on a probe. And on the screen here, you can see a picture of what a TTE probe looks like. We do try and keep the jelly as warm as possible. Probe is placed on the chest in various positions, and it lasts for approximately 30 to 45 minutes. So some indications for transthoracic echocardiogram include shortness of breath, dyspnea on exertion, murmur, chest pain, passing out, arrhythmias or abnormal heartbeats, evaluate for endocarditis or vegetations on valves, for shunt evaluation such as a PFO or an ASD, TIA or stroke, therapeutic drug monitoring. Certain chemotherapies can cause alterations in systolic function or the pumping function of the heart, so we do monitor that closely with TTE, and then congenital heart disease. The purpose of the ultrasound jelly is to provide a medium. So one, it is not as painful. Let's say I should actually use the word painful. It's not painful, but you don't want the probe sitting on the chest dry. The jelly allows for improved contact, if that makes sense. So you do actually need the jelly on the chest, and we use a fair amount of it. One, it's for comfort, but also it does improve the imaging processing. And thank you. So TTE, no pictures yet. Can you see the slides? Oh. Pictures are coming up. So TTE is first line for cardiac imaging. It's a standardized examination that looks at cardiac anatomy and hemodynamics. So we have multiple locations on the chest in different views or different imaging planes. So we start with the parasternal, which is done in the 4th intercostal space in the middle of the chest. The apicals are in the 5th or 6th intercostal space on the side of the chest. Subcostal is on the stomach, right to the left of the xiphoid process, which is that bony process right at the bottom of your chest. And the suprasternal notch, which is on the neck above the sternum. And so here are some of the commonly used views to evaluate specific structures. So we'll go through all of these. This was just a slide to show you all the structures we're looking at and that they're seen in multiple different views. So we are evaluating these structures in multiple views. So the TTE views, the parasternal is what we start with. The long axis looks at the left ventricle, which is the pumping chamber of the heart, that main chamber on the left side, and LV wall thickness. It also looks at the left atrium, the aortic root, and the ascending aorta. The probe is then turned, and you see short axis, which looks for wall motion and valve assessment. And here is a video of that parasternal long axis. So what you're seeing, I'm not sure if you can actually see, I'm pointing, I can't see my point. So on the very top, if you look from the top of the slide going down, that's the right ventricle. Then the main chamber you're looking at is the left ventricle. That thing that's opening and closing that you see the best, that's the mitral valve. And the one right above it is the aortic valve that leads out into the aorta. Here we could also look if there was any fluid around the heart, which there is none in this picture. But this is the first image that we start with, and you can see the pump and function of the heart, and this heart is doing a great job. And so again, here it's showing us that same parasternal long axis, but all of the things that we can actually see in this slide. So you can see the walls, we can measure the walls, we can measure the size of the left ventricle, and we can see these chambers that are here. So this first image actually does give us a lot of information. And the parasternal short axis view, I did want to give you an idea of where on the chest it was, so you can see it's in that 4th intercostal space right in the middle of the chest. And basically to get the short axis view, they just turn the probe ever so slightly, and the heart, instead of being elongated, becomes round. And there are 3 different views we look at. There's a valvular view that gives us the tricuspid, aortic, and pulmonic valve. Then we go down the left ventricle to look at wall motion. The mitral valve comes in a different view down that left ventricle. And here's the short axis view. That valve right in the middle that looks like a Mercedes-Benz sign, that's the aortic valve. It's from the left ventricle out into the aorta. Just to the left of it is the tricuspid valve, and to the right of it is the pulmonic valve. And here we have those short axis views that we talked about going down. The view on the left shows you the mitral valve, and the view on the right is just further down into the left ventricle, and you can see the capillary muscles, which are a part of the mitral valve apparatus. On top of the left ventricle, which is that big circle you see right in the middle, is the right ventricle. Then we move on to the apical views. There's a 4-chamber view, which shows the left side and the right side, their size and function, the left atrium and the right atrium. We also can measure the volume of the atria, which are the 2 top chambers of the heart. We look at the mitral and tricuspid valves and do color and Doppler, which help us assess for any leakiness or stenosis. And then we look at diastolic function, or the relaxing function of the heart. And this is that apical 4-chamber view. On the left side is the right atrium and the right ventricle. And on the right side of the picture is the left atrium and the left ventricle. The ventricles are closest to the top of the slide. The atria are closest to the bottom of the slide. And here we can see the whole heart pumping. And here's pulse wave and continuous wave. This again is just waves that we can do. The transmitral pulse wave gives us an idea of diastolic function. And the continuous wave of the tricuspid valve gives us pulmonary artery pressures, as well as if there's any leakiness. It's okay to have leakiness of the tricuspid valve as long as it's not any more than mild. Then we move to the 5-chamber, which again shows us the left and right side of the heart, the mitral, tricuspid, but then it also shows us the outflow tract, which is leaving the left ventricle into the aorta, and it shows us the aortic valve, and this is one of the views we can look for aortic stenosis and regurgitation, and it also shows us the proximal portion, or that early portion of the aortic root, which is part of the aorta. And so here's just a picture of that. You can see the difference between the 4 and the 5-chamber. Now there's that something right in the middle of the picture, and that's the aortic valve. And here's how we evaluate for aortic stenosis. On the left is a pulse Doppler, on the right is continuous wave Doppler, and we measure these, and we can measure gradients, and this is how we determine through some equations what the valve area is, and that's how we determine whether or not there is any aortic stenosis. Then we move on to 2-chamber, which is just the left ventricle and the left atrium. It shows us different walls of the heart than the other views have, so it is an important view to see as well, and it shows us the mitral valve. And here's a picture of that, or video. And then we get the apical 3-chamber, or the long axis. It looks at LV function and wall motion. Again, it's a different wall than the walls we just saw in the 2-chamber, and it shows us the mitral and aortic valves. It actually looks just like that parasternal long axis, the very first image we saw, but we obtain it in a different view. So it'll actually be standing upright as opposed to lying on its side. But those walls are actually the same in the parasternal long axis as they are in the apical 3-chamber. Then we move on to the subcostal view. That again is right on the belly. It shows us the right side of the heart, the intraatrial septum, which is a connection between the right atrium and the left atrium, the tricuspid valve, the pericardium, which surrounds the heart, and if there's any fluid in there, we would see it best in this view, and the IVC, or the inferior vena cava, which is the vein that brings blood back to the heart from the lower part of the body. And here are some videos of that. On the left side is, again, that subcostal view that shows the whole heart. And on the right side is the IVC, and it should collapse. They'll ask you, the sonographers, to sniff. And what the sniff does is it should show you that the IVC collapses, which is normal. And here's just a view of what a pericardial effusion, or fluid around the heart, would look like. That black area around it is fluid and should not be there. Everyone can have a tiny little bit of fluid, but you shouldn't have as much as seen in this picture. Then the end of the exam is the suprasternal notch. It's right under the chin and the neck, and that looks at the aorta. And it gives you the arch, and it's a way to identify congenital heart disease, or a coarctation of the aorta, which is a narrowing of the aorta. And you can see that on the next slide. And you can see on the left side, that is the arch that you're seeing come up and around. And all of that color on the right side, you see how it's that mosaic color, that shows that there's increased velocities, which we would see in something like a coarctation. Okay. So that's transthoracic echocardiogram. That is one of the more common imaging studies that we do. Now we move on to transesophageal echocardiogram, which is a complement to transthoracic. There are some cases where we would go immediately to a transesophageal before doing TE or transthoracic. Normally we do transthoracic first and then move on to TE as needed, except for in the following cases. Anyone who has atrial fibrillation or atrial flutter, and we're going to do a cardioversion or shock the heart back to regular rhythm, and they have not been on 4 weeks of anticoagulation, or it's a new diagnosis, we would do TE first to make sure there's no thrombus in the left atrial appendage. If someone is having a valve procedure or valve surgery, we would do TE. To look for a cardioembolic source, we need to look for a blood clot in the heart, especially that left atrial appendage, when no other source has been identified, and to assess for endocarditis, or again bacteria on the heart valve, if there's a very high probability. Some bacteria will cause endocarditis very frequently, so we would go right to a transesophageal echo, as some of the valves are much better seen on TE. We also use it for guidance for structural procedures, so a Watchman device, which is a left atrial appendage occlusion device in patients with atrial fibrillation. MitraClip, which is used to clip the mitral valve leaflets together in patients with severe mitral regurgitation, or TAVR, which is a way to treat aortic stenosis percutaneously without having open heart surgery. So TEE, what we do, here's an example of a TEE probe. If anyone has ever had an EGD or endoscopy, they look very similar. We insert the probe into the esophagus and into the stomach and take pictures along the way. There is sedation involved, so people are normally not awake during this procedure. It is invasive, so complications can arise. With transthoracic, it's a non-invasive procedure. TE is invasive, and those complications are less than 2%. And the probe lies directly posterior to the heart with very little interference from the lungs or the ribs, which is what interferes with our transthoracic echocardiogram. So it's best to see the left-sided structures of the heart. So this is just an example of what it looks like. We take pictures in the upper mid esophagus, in the transgastric, which is a stomach, and then the deep transgastric, which again is just in the stomach. And you can see on the left side of the slide that the probe rotates from side to side, and we can move the probe side to side and up and down to help get all of our pictures. And so unfortunately, I don't have as pretty pictures as for TTE, but this again will just show you what our TE pictures look like. And so we're looking at the heart in the same way as we did transthoracic. We're looking at the left ventricle, the right ventricle, the pumping function, the valves, and we're looking at them in all different views to get those valves in different views and to look at the heart walls themselves in different views. And this, we'll go through this quickly because again, you can kind of review it if you're interested. It just shows us all the different images that are being evaluated. Well, the one thing that TE shows us better than TTE is the pulmonic valve, which is not well seen on transthoracic, but is better seen on TE. And that left atrial appendage, which is a little outpouching in the left atrium, which is the top chamber of the heart on the left side. And that is where thrombus or clot can form. And so that's something that we see very well in TEE. It's not seen nearly at all in transthoracic echocardiogram. You can go through these. And again, these are just pictures looking at everything, and we can also look at the septum. These are the gastric pictures, so you can see it looks like that parasternal short axis because the left ventricle is round. And then we can change the angle to make it longer. And then we also the aorta as well. And that's the aorta. And this is a video of what transesophageal echo looks like. This is a 3-chamber. And so it actually is reversed from the transthoracic. So the top part of the screen is the left atrium. Then you're seeing the mitral valve. Then the left ventricle on the bottom. And the valve that's over to the right, that's the aortic valve. And what you can see is that the sound and pictures are gone. Can you not hear me at all? Okay. You can hear? Okay. So the mitral valve is that valve that's on the top, and what you can see is we can see the different leaflets. There's an anterior and posterior leaflet of the valve, and here the posterior leaflet, which is the one all the way to the left side of the screen, is bowing up into the left atrium. So that's actually not normal. The valve should not look like that. And this is color of that same valve, and you can see all of that color that's coming back up into the left atrium. That's not normal, that's severe mitral regurgitation. They also have some aortic regurgitation, which you can see that's that color that's coming back into the left ventricle from the valve on the right. So this is a way that we can very easily tell that there is pathology in that valve. And this is a schematic of the mitral valve and all the different views. So we can see the mitral valve in many views on transesophageal. And this schematic that you're looking at is what we call the surgeon's view. So it's what the surgeons see when they do open heart surgery. But any of the imaging we do, this is the view that we'll go ahead and give our surgeons or anyone doing a valve procedure to help them assess the valve. So the aortic valve is on top, the mitral valve is right in the middle with the anterior leaflet on top and the posterior leaflet on the bottom, and the left atrial appendage is to the left. And this is the mitral valve in 3D. We do a 3D rendering of it, and that's that surgeon's view that we're talking about. So the anterior leaflet is the one on top, the posterior leaflet is the one on the bottom. And this is what it would look like if we actually were looking, opening up the mitral valve. And so you can look at it, this is what it would look like. So it's kind of a cool technology to do, and it does help us really look at the valve and look at all of the leaflets to tell what the exact leaflet problem is. So before I go on to cardiac CT, I see there's a question about TTE or TEE to be used for pulmonary hypertension. Transthoracic echocardiogram is the better diagnostic tool for pulmonary hypertension, and the way we do that is we look at the tricuspid regurgitation. So that was, if you remember from a few slides ago, that continuous wave Doppler, and it gave us a profile, and we measured the highest velocity. And that tells us what the right ventricular systolic pressure is. You add that to the right atrial pressure, and that gives us an idea of what the pulmonary pressures are. And so that's how we can assess for if we think that there is pulmonary hypertension. Thoracic is really the better study to do that with. However, you need to have a leakiness of the tricuspid valve. If there's not a good TR jet or tricuspid regurgitation jet, we actually can't assess it well. The definitive diagnosis for pulmonary hypertension is actually right heart catheterization, which is an invasive procedure. All right, moving on to cardiac CT. But if anyone has any questions about TE or TE, please continue to put them in the question box. So cardiac CT, most often when we think about it, is a contrast coronary CT angiography, or CCT. Basically, it means we give contrast. And we look at the coronary arteries. So it's a way to evaluate for coronary artery disease without doing a cardiac catheterization. We normally would use it in patients who have what's called stable angina or heart pain, heart discomfort, chest discomfort that is stable. In patients who have an acute coronary syndrome, which means concerning for a chest pain that has changed from stable angina or new chest pain. In patients who are low or intermediate risk for having heart disease. So we think someone's very high risk that they're having a heart issue, they would go for cardiac catheterization. This is for patients where that risk is low. It identifies coronary stenosis and coronary plaque. So basically what happens is there's a contrast, and it's iodinated contrast. Then right before they start the exam, you get a sublingual nitroglycerin, which is a little pill right under the tongue, and that dilates all the coronary arteries. Can you see the pictures anymore? Very cool. Very cool. And so it dilates the coronary arteries for us. And then right before it, there's beta blocker or calcium channel blocker to slow the heart rate. We want the heart rate to be less than 70 beats per minute, closer to 50 to 60. And people have to be able to hold their breath for at least 5 to 10 seconds. So it's not always the best exam if anyone has trouble doing that. Contraindications for cardiac CT is any renal insufficiency or a GFR less than 30, and that's just a measure of kidney function, or if there's any allergy to contrast dye. So cardiac CT will detect a blockage or narrowing in coronary arteries of greater than 50%. And there's a score that is used if patients have either stable chest pain or acute chest pain. And here is that score that breaks it down for stable chest pain. And here's that same score for acute chest pain. So again, it's going to score them a little bit differently based on the presentation. And here's a picture of what it looks like. So again, it's a very nice diagram. So on the left is 3D reconstruction, or that 3D rendering of all the coronary arteries. A, which is all the way on the left side of the heart, is the right coronary artery, and you can see what that looks like in the CT. B is the left anterior descending artery, or the LED, and that you can see is also labeled B on the 3D rendering. And C is the left circumflex. So you can see how nice and plump these are, and you can visualize them in both 3D and 2D. And here on the left side is the coronary CT that shows narrowing, and I hope you all can see those red arrows in the right coronary artery. And then on the right side is that same picture at cardiac catheterization. You can see how narrow that is, and that was picked up on coronary CT. And that is what the next step would be. If blockages or narrowings are seen on CT, then the next step would be cardiac catheterization. And here again is just a fun 3D rendering of cardiac CT. So you can see all, that's a nice pretty picture. All right, now another thing that CT can do for us is a coronary artery calcium score, or a CAC score. There has been an association seen in calcium in vessels and coronary atherosclerosis, or plaque in the coronary arteries. And we can see coronary artery calcification on most CAT scan imaging. So even if a CAT scan was not done to assess the coronaries, we can still see calcium in the arteries. And it's used as a risk assessment tool only. So the appropriate patient would be an asymptomatic adult greater than 40 who has intermediate risk of having heart disease. And there's something called an ASCVD risk score. Your primary care physician or cardiologist may have talked to you about this before, and this score basically helps us determine what your risk of having heart disease is. An intermediate risk score is a score of 7.5 to 19.9% in 10 years. Borderline risk scores are 5 to 7.4%, and we could do a CAC score in patients with a family history of early cardiovascular disease, or a PACC score, depending on who you talk to. It's non-contrast CT. There's no preparation or premedications like in the coronary CAT scan. And there's a scoring that's done that sums all the coronary calcium seen in the coronary arteries. So 0 is none, 1 to 99 is mild, 100 to 399 is moderate, and anything greater than or equal to 400 is considered severe. And on the left-hand side of the screen, you'll see a CAC score of 0, which means no calcium at all. And pardon me, calcium is seen as bright white on CAT scan. So you can see the difference between the left and the right picture. You see all that bright white on that right picture. That's calcium in all of the arteries that you're seeing. And that big blob of white right in the middle is the left anterior descending. So that would be a severe CAC score. And the reason that we do this is it does help with risk assessment, but then also medical management. So in people who have that intermediate risk, that greater than 7.5 to 19.9%, we would actually recommend statin therapy. And if there's a question of, I'm not sure if I want to take a statin or I've had issues with statins in the past, if the CAC score is 0, then we could say, actually, you don't need a statin. But if it's greater than 0, then we say, go ahead and get the statin. So it can reclassify your risk up or down. With that borderline risk, 5 to 7.5, we would again say we should consider statin therapy. If the CAC score is 0, no statin recommended. But if greater than 0, then we would recommend consideration of statin. In people who are low risk, less than 5%, the CAC score is actually not recommended because they're low risk and it wouldn't change our therapy. If the score is greater than 20, statins are always recommended across the board. And then again, the CAC score would not be effective in the population because it won't change our medical therapy. And yes, the CAC scores are determined only by imaging, only by this non-contrast CT. And then we'll wrap up with cardiac MRI. It's used to assess function as well as myocardial tissue. So it tells us about the right and left side pumping function of the heart, but it also tells us about the myocardium itself, the tissue of the heart. It's used as second-line testing after echocardiogram. Sometimes contrast can be used. This is a different type of contrast from CT scan. This is called gadolinium. This is contraindicated if the GFR is less than 30. So indications for cardiac MRI include ischemia, inflammation, infiltrative disorders. So there are some disorders that can deposit into the heart itself, and so we call those infiltrative disorders. Sarcoid and amyloid are the ones that are the most common. Valvular disease, pericardial disease, aortic disease, and cardiac tumors. Contraindications to MRI are metallic or electrical devices or implants, or severe renal insufficiency if using contrast. And the reason that metallic or electrical devices are contraindications is that they can cause, one, they can move with MRI. There are some devices that are what we call MRI conditional, meaning you can get an MRI with them, but depending on where they are, they can impact visualization of certain structures. Next slide. So advantages and disadvantages of cardiac MRI. Advantages are it's three-dimensional, high resolution. It has intrinsic high contrast, so you don't actually normally need contrast unless you're looking for other specific things. There's no ionizing radiation. There's no interference from lung or bone, and there's multiple imaging techniques in a single system, meaning we get multiple different views and multiple different slices and weights, so we can look at different things in one system. Disadvantages, again, it's contraindicated with certain medical implants and certain pacemakers. Newer pacemakers and defibrillators are cardiac conditional, so it would just depend on what the device was. Acquisition time can be very lengthy. EKG can be distorted by the magnetic field, so in acutely ill patients, we want to monitor them all the time. This can make it a little bit challenging. It does require EKG and respiratory gating, so again, having to hold your breath for a certain length of time. And claustrophobia is a big issue because it is an MRI machine. And so here's just a view of cardiac MRI in aortic disease, and this shows a dissection. You can see here there's a flap, which is what that arrow is pointing to. There's something called a true lumen. That's the true lumen of the aorta. That should be there. And right below it, you see that gray is a false lumen, and that's because there's blood or clot in there. And so that actually should not be there. And we can see dissection on cardiac MRI. For pericardial disease, it can look for something called constrictive pericarditis, tumors, or congenital absence of the pericardium. So some people are born without a pericardial sac. For myocardial disease, we can look if someone has had a heart attack in the past and we want to see how big it was, how much damage was done. It will show us infarct size. There's something called myocardial viability, and that tells us if it looks like there's an area of blood, an area of the heart that's not getting as much blood as other areas. There's something called hibernating myocardium, and the cardiac MRI can actually tell us if those areas are viable and if that area of the heart would benefit from revascularization, either with stenting or bypass surgery. Again, infiltrated diseases, it will show us that amyloid or sarcoid we talked about, hypertrophic cardiomyopathy, myocarditis or inflammation of the heart, the myocardium itself, stress testing, or any fibrosis or thickening of the heart. I will say, if you've been seeing in the news recently, especially with COVID, myocarditis is a risk that is associated with COVID, and we've seen a lot of people have myocarditis after having COVID-19, and cardiac MRI is one of the ways we can tell if that's happened. Next slide. And here are just some pictures. This is someone who's had a heart attack, and they used gadolinium. What the gadolinium is showing is the enhancement, and these are people who have had big heart attacks, essentially. So what you'll see is that you see the enhancements. Hoping that it's coming through for you. That white part that's going in, or the hyper-enhanced region, is evidence of a large infarct or a large heart attack. And here's that viability that we were talking about. And so the bottom picture is what you would see with SPECT, which is a way that we look at blood distribution in the heart. So if anyone's had a nuclear medicine stress test before in the past, this is what those look like. And you can see on the left-hand side, that rest picture, you see an area that is not yellow. And then on the right-hand side, you see that part of it has actually filled in. And you can see that as well in the MRI picture itself. And that means that that area is viable and would benefit from revascularization. For valve lesions, we can see regurgitant lesions or stenotic lesions. So we can see both of those on cardiac MRI. And questions. So I do see that there's a few questions. The relationship between the coronary artery calcium testing and cholesterol scores, it doesn't correlate directly. So somebody could have a very high coronary artery calcium score without having very high cholesterol. But what a high coronary artery calcium score does correlate with is atherosclerosis or blockages in coronary arteries. So that's why we recommend statin therapy based on that score. And again, it takes into account your 10 years, your ASCVD risk score, but also the degree of calcium for those borderline or intermediate risk patients. If that 10-year risk is greater than 20%, statin therapy is always indicated, regardless of what your baseline cholesterol is, and regardless of the calcium score. If your risk is less than 5%, that ASCVD 10-year risk, we actually wouldn't recommend doing a calcium score. We wouldn't recommend statin therapy unless your cholesterol were quite elevated, above the normal levels. For the cardiac MRI, acquisition times are lengthy. They're at least an hour, sometimes longer. And here's all the references. If you want to take a look at any of those pictures and see. Any other questions about any of the testing? Again, this is just kind of an overview of testing. There's more testing we do. There's stress testing we could do, etc. But this is just an overview. If Lipitor makes muscle hurt, I like rosuvastatin or Crestor. If atorvastatin has given any issues in the past. The other thing that can be done is something called coenzyme Q10, taken in addition with your statin. I would say, and I've had good success with that every single person can be on a statin. It just depends on which one and the dosing. So definitely talk to your provider about that. Sometimes what I'll do is if patients have had statin myopathies or had that muscle ache from statins is I start off maybe 3 days a week for a few weeks, and then we gradually increase it. And that when we do that, for whatever reason, those muscle aches actually tend not to come back again. So transthoracic echocardiogram is done at our offices. So it's done at the Port Warwick office, the Hampton office, the Hampton Diagnostic Center, which is just 3 doors down from our Hampton office. It's also occasionally done in the hospital. And if you're in the hospital for whatever reason, they do them in the hospital as well. Transesophageal echocardiogram is a procedure, so you would have to come in. We do them outpatient and inpatient, but you would come in that day, we would do the procedure, and you'd go home same day, but that's always done in the hospital. Coronary artery calcium scores and coronary CTs are done at a variety of locations who do scans. So some of the diagnostic centers do CAT scans, and the same thing for cardiac MRI. And I do believe at regional, the hospital will that is something that is in the works to do as well. Did I miss any questions? Thank you all. Any other questions before we sign off?